Jared, I know we talked a little bit before, but still, like, can you introduce yourself a little bit for the audience in Taiwan?
I wish I had have known how to say good evening in Taiwanese. But anyway, my name's Jarrod Antflick. I am a sports physiotherapist with a very keen interest in tendons, and I've done that for quite some time. I'm currently doing a PhD in bioengineering at Imperial College London, and I'm a clinician, so I do a clinic for 5 hours a week at a physio clinic, normal physio clinic, where we do testing and use sports platforms and ultrasound, et cetera, et cetera. And then I do another clinic at a place called Fortius Clinic London, which I've been at for 12 years. And we do only tendons, Achilles, patella, and quad tendons. And I do it with a consultant, Dr. John Houghton, who I've done that with for about 8 years now. And we do our clinical history, ultrasound, UTC, and then depending on what they need, they might go off for an injection. They might just have loading. They might have need to go and see one of our consultants for surgery. And then I work in the NBA and the NFL, but most of the NBA, helping teams understand those athletes that might be at a little bit more risk of tendinopathy. And I do that with a UTC scanner.
Cool, cool. So
Hmm.
the main reason I want to invite you on is because like when we met at Summer League, there's a presentation about like the injury mechanism of like Achilles tendon rupture and injury prior to Achilles tendon rupture. And I remember we
Yes.
talked a little bit about that. And if I remember correctly, the research said that in the NBA, at least in the NBA, for all the Achilles tendon tear, either there's a calf strain, plantar fasciitis, or some sort of like foot issue. And like over 100, like I think 100% of the Achilles tendon tear is uh some sort of false step mechanism. So can you share your
Mm.
thoughts on this?
I think I remember this conversation now. So it was a very busy time. Um, so the injury mechanism, I think there's been talk about it being as you step back, has a high eccentric force to then push off. And you're never going to change that in the NBA. That is something that these athletes do tens of thousands of times, even probably more in their career. I think the mechanism of Achilles rupture, because I think that's what alluding to, there was 8 or 9 last season, none so far this season, touch wood. Um, but I think the mechanism is not that clear. What we do know is that normal, healthy tendons don't rupture. Okay. Unless they're steroid induced or corticosteroid induced, or they have taken a fluoroquinolone, which is a very strong antibiotic that's used for urinary tract infections or gut infections. But normal tendons don't rupture. And so any of these tendons that are rupturing have structural disorganization or changes within the tendon structure. The matrix is disorganized. And that is why they rupture. So you'll very rarely, if ever, never see a tendon that has ruptured that is structurally normal. Now, coming back to your original question around the biomechanics of it, I'm not sure there really is the biomechanics of it. There have been people that have talked about trunk position and trunk lean, and I don't think you're ever going to change that. The only thing that I think is that things that are modifiable, and I think that's what we need to look at, the modifiables and the non-modifiables. The non-modifiables are previous injury history, age. If they've taken fluoroquinolones or corticosteroid, there's not much you can do about that. That's already occurred, and they're just not changeable. But the things that you can change are the modifiables, and they are strength, which is very, very key. Their train and game loads are very important. Their body mass, potentially some of their footwear type, but that's not really a proven thing at the moment, a proven variable. So I think at this point it's a bit difficult to say that there's the biomechanics of rupture because these guys move in very unusual ways, and some of them, that's what makes them the athlete they are. That's what makes them special. And so changing that might make them less special or less athletic. I remember having these conversations with Russell Westbrook, and I'm sorry, I don't mean to name drop, but he has an incredible first step. And I asked him, I said, Russ, this was years ago when I think he was at the he was at the Houston Rockets. I said, Russ, you must have trained track and field. And he said, yeah, it's exactly what I did. Now, the rupture rates in track and field is very, very high as well because the loads are really, really high. Contact times are very short, forces are very high. And so, not that Russ has got any tendon problems, I'm not implying that at all, actually, contrary to that. But, um, that's what makes Russ special. And to turn around and say, oh, Russ, I need you to go a bit slower as you push off is just ludicrous. So, in answer to your question, is there the biomechanics of tendon rupture? Yeah, sure, they step back, but is that ever going to change? Is that something that we can change? Absolutely not. I think it would be remiss to think that you could. But interestingly, I think there are other factors that are at play, and I would hope that the NBA starts to look at some of those rather than trying to run kinematics, in-game kinematics, looking at tendon ruptures because that's an after the fact. The tendon damage has occurred already. It's not something that's occurred because they did that step back. It's because, they've been playing really high game loads or high training minutes, or conversely, they haven't done, and then they have done a lot of training and game loads to get them ready for a game. Coming back to your question around calf injuries, yeah. So I think some of it comes down to NBA reporting, and I don't want to put my toes in too much hot water, but I think the NBA is a business entity unto itself, and we have to be very careful about what I say. But I think the reporting on some of these injuries can be a little bit misleading in terms of maybe these what we're calling calf injuries are calf injuries, but are tendon injuries. So we all know that the Achilles tendon from the calcaneus, as it extends, becomes a free tendon and attaches up into the soleus. The soleus has, upwards of five aponeuroses, but usually three: medial, lateral, and central. And Carlos Pedretta's talked about that at length. But I think some of these Achilles ruptures that have come from calf injuries potentially were not that. They were probably tendon injuries to start with. Although, if you compromise the muscle proximal to the tendon, arguably you could say that might lead to tendon rupture. But I'm not sure that in any systematic review that that's been demonstrated that calf injuries are a precursor or a predisposing factor for tendon rupture. Maybe tendinopathy, but not tendon rupture.
Nice, nice. So you're saying like those tendon rupture potentially already have like some sort of tendon injury or like tendon
Yeah.
changes. So
Mm.
uh I mean in those situations like those guys that play high minutes, they're probably still gonna play high minutes.
That's right.
So like is there a way to like in your mind, is there a way to like maybe help them stay healthy?
So that's a really good question, and I've been on my soapbox about this for years. The only way to prevent tendinopathy that we know that's really quite, has a high usefulness is really strength training in the off season. So what I found, I've been in this is my 12th or 13th season in the NBA, is that unfortunately, I think a lot of the off season for some of the players is not spent doing the kinds of strength work that is going to prevent any injury, let alone tendon injuries. And so, how do you prevent these sorts of injuries? Yeah, look, you're never going to stop high minute guys playing high minutes. They'll stop themselves doing it because they have the right to do that, sort of. Um, but it's about preparing them for that 82 game regular season and those high minutes. I remember working with the Rockets years ago when Mike D'Antoni was there, and he basically his practice sessions were very, very light. And that made a big difference for someone like James Harden, who not that he's had a tendon injury. I'm not saying that. I'm saying that he was able to play ridiculously high minutes because the training sessions weren't that high. And in fact, some of the players could turn up in their socks and just walk around the court because that's how Mike liked to do things. But it's I think if you have very high training minutes and intense game loads, I think that's a recipe for potential injury. But I think really it comes as preparing these athletes for those high game minutes, and that comes from being super strong, loading in the preseason, and that doesn't mean on court playing basketball. That means actually doing strength work.
Nice, nice. So another question related to this is like, I think it's during the summer. I think it's Paul George and Kevin Garnett are talking about like all these Achilles tendon injury about on their podcast. They're saying like back in like maybe 10 or 15 years ago, the way they practice, the speed they practice is way higher, the intensity in practice is way higher. And they say that probably help them be more healthier in terms of like tendinopathy or like Achilles tendon injury for those situations. Uh, what are your thoughts on this?
I mean, I can't really comment because I didn't see the podcast, but what I would say is we know now the game is considerably faster than it's ever been. Okay. So it's a much faster game, velocity wise. And, you know, yeah, there's always been a shot clock, but the game speed has increased rapidly. And so I think that does make a big difference. Now, you know, training sessions probably were a lot tougher back then, but the games ran a lot slower. There was not a huge amount of fast court work, and actually the three wasn't. It wasn't a, you know, the spacing of the game was very different. People didn't shoot a lot of threes back then. Not to say they didn't. I'm just saying the volume of threes that's being shot now, and what that does is it spaces the court more, and it requires players to run out to the 3 point line more rather than crowding the key. So, you know, in answer to that question, yeah, they probably did play harder games, but the harder training sessions, but the games were a little bit different and the game was a little bit different.
Nice, nice, nice. So, uh, before we dive into like training for Achilles tendon, I want to ask a related like yeah, it's probably related, but some people would say the patellar tendon function different than Achilles tendon, although they're both tendon. So why is it like why are people saying like these two function differently?
I mean, arguably you could say it's a bit like a ligament, but it is a tendon. You know, it actually is a tendon. It very much looks like a tendon. And it doesn't look like a ligament at all, particularly. I mean, I do spend a lot of time in theatre, doing operations, guiding under ultrasound. So I have the beauty of having an ultrasound and actually having a scope in front of me. So I see tendons very often under ultrasound and under arthroscopy. So they are tendons, but potentially the loading rates are less in the patellar tendon, which is why players can have patellar tendinopathy and not be as symptomatic as what if that lesion existed in the Achilles tendon, they would be symptomatic. So patellar tendon, the loading rates are lower. There's a lot more other musculature around. You've got the calf muscle, which crosses the knee joint. You've got the hamstrings as well, which helps to slow down the knee, and the shank. So I think part of it is might seem like it's a little bit different. It is still a tendon. It's a sesamoid tendon, so obviously the patella is a sesamoid bone, and we launched the tendon unit, which we've had for a while, but really a more unified manner in London at Fortius. And we presented some of our outcome data for 60 odd patella tendon ultrasound guided debridements that I've done with Mr. Sam Church and now Mr. Sanjay Nan. And what we found is that if we look at the position of the patella in relation to what is normal, I think something like 58 of 62 tendons that we've operated on were considered patella alta, which means their kneecap is sitting quite high. We're going to publish that work when we get a little bit more 12-month follow-up data, but what seems to be the case is everybody that has, or the players that have really bad patella tendinopathy are very alta, meaning their kneecap sits very high. And I've found seeing those athletes, they have extremely large calf muscles and very small quad muscles. And when you're patella alta, the engagement of your cartilage surface is much higher. So some people actually, their cartilage underneath their kneecap sits above the cartilage on the medial and femoral condyles. But equally, the relationship as a force generator becomes diminished when the kneecap sits too high. So when you have a really high kneecap, the mechanical advantage is considerably less, and therefore the strain on the tendon, even at lower loads, is much higher. And we're it's going to be a joint project with Imperial and Fortius where we actually set up on a jig using indwelling force sensors in patella tendons and basically just position the patella and look at the kinds of straining loads that are on the patella tendon in different positions of the patella. But what we found clinically in all of our patients, and we keep quite well, very, very detailed records of those we've operated on and outcomes as well, is that those that are very alter, they have lots of patella tendinopathy, and those that are above what we call Blackburn Peeling Index or the BPI, it's a relationship between the patella and the tibial plateau and the cartilage surface. When their BPI is above 1.2, chances are they'll probably do quite poorly with an ultrasound guided patella tendon debridement. And actually, we need to do a TTO. And so we've done that quite a few times where we actually just change the distal insertion. We just drop it down a little bit, anywhere between 10 and 15, on one occasion, 20 mils. And that stops the patella being so alter and actually improves the mechanical advantage of the tendon. So anyway, side note.
Nice. So, also there's also some coaches say like after Achilles tendon, like patella tendon's a new kid around the corner, like potentially like gonna get more injury on that like that area. Like, what are your
You
thoughts
mean
on it?
after they've had an Achilles injury?
No, no, like after like all these Achilles injury that happened in the past few years,
Hmm.
potentially like people are looking more into Achilles tendon or calf, and the new kid around the corner is probably patella tendon.
I mean, I don't think it's a new kid. I think it's always been there. I think the injury surveillance in the NBA, when I looked at doing some research in the NBA, which didn't eventually happen for a bunch of reasons, but um, when we look at the data of patella tendinopathy, which is rife in the NBA, there is not a team I go to or have seen where there isn't many cases of patella tendinopathy. The problem is the injury surveillance just talks about anterior knee pain. And that anterior knee pain could be patellofemoral, but it's highly likely to be patella tendon. And the reason why I say it's unlikely to be patellofemoral is because at that level of athlete, quite often, if you have horrific patellofemoral pain, you probably won't make it to the NBA. They're kind of self-selecting. And so chances are a lot of these athletes and a lot of the injury surveillance that says anterior knee pain is likely patella tendinopathy. Or it could be superlateral fat pad impingement or fat pad impingement or something like that, but quite likely a lot of it is patella tendinopathy.
All right, this is interesting because I was actually talking to another like strength coach. They say a lot of it, a lot of it is probably patellofemoral pain, and like someone else also say like there's probably 50-50 patellofemoral and 50-50 like patella tendon.
I would disagree entirely. I would suggest that, and I've scanned for the last 12 years thousands and thousands and thousands of players, and I can tell you that in my experience that a lot of these injuries are patella tendon. As I said, for that reason, because if you have lots of patellofemoral, you can play with patella tendinopathy, right?
Yeah, yeah,
It takes a while to warm up, and you can do your strength work, and it can go away. But if you have patellofemoral issues and you have had patellofemoral issues for a while, you're unlikely to be able to, um, to play through it. It's one of those things where it just kind of stops you. So I would suggest that it's probably 90-10 or 80-20 teletendon rather than patellofemoral.
nice,
Maybe
nice,
fat pad impingement is in there as well, but yeah, I think a lot of it is patellotendon. I think it's just
nice,
underreported.
nice, nice. So, all right, so uh, a lot of research that done on tendon is the participants mainly like just not athlete, right? A lot of like the isometric or like eccentric, the research just done on like just regular person, normal people. So
Hmm.
like in terms of like training the tendon, no matter it's like Achilles tendon or patella tendon, do you think like eccentric, like oh sorry, isometric, heavy isometric or heavy eccentric is gonna help prevent or like I don't know.
You mean treat or
Yeah.
prevent?
Yeah.
If you want to talk about prevention, it's about quad strengthening, getting them really strong. If you want to talk about management, it's the same thing. So the most useful paper that's ever been published on it is by the Danish group in Copenhagen, which is Peter Magnussen and Michael Kjær's group. It was a Mads Konsgaard paper looking at, corticosteroid injection, decline squat, heavy slow resistance. And it's heavy slow resistance that's going to change. So what does the tendon respond to? It responds to strain. Full stop. Number one is strain. Now, strain can come in many different forms. It can come in short, so very quick contacts, very, very long, or somewhere in between. We know that strain has to be around 5 to 7%. It generally can't be very short. So if you want to apply a little bit of Achilles research to patella tendons, and you look at the Aaron Patz's paper, they found that if you reduce the contraction duration from 3 seconds to 1 second, the effect was less. So you need some level of strain that's over a period of time. Now, if you're asking me, do I think analgesic loading works? I don't think the research is particularly strong, but I think if you have an athlete that responds to it, then I don't have a problem with it. I think those athletes with patella tendinopathy, if I come back to my original comment around being patella alter, that the majority of them are, or at least the ones that we've seen are majority are patella alter, is that they don't like knee extension because their patella is sitting high. And so if you look at, and I managed to speak with Ebony some many, many years ago when she and I met at a conference and we talked about, how her cohort group, and her cohort group was really big to start with, and it came down to six for a bunch of different reasons. But potentially some of these athletes or some of these patients in her paper on the analgesic loading paper might not, and I don't know, I don't really know exactly why all of them, why she had such a huge dropout. But potentially, it could be that these athletes or these patients don't like doing knee extension because that's predominantly where analgesic loading is done. So if you think, and in terms of our research, so when we publish it, they will be over 60 cases. Nobody's published a paper on 60 cases of patellar tendon debridement and at this detail. It's just not been done yet. Maybe it will be until it gets published. But when we look at all of those cases, 95% of them are patella altered. Their BPI is over 1.1, 1.2. Normal is between zero point 0.8 and 1. So all of these cases are alter. We then put them on a knee extension machine, which typically most people that are altered don't like doing knee extension because of where their kneecap sits to start with. That maybe that's why the analgesic loading paper didn't have a huge number or why it doesn't work in some athletes. I don't know. But what I do know is that if I have an athlete that has patella tendinopathy, I am going to get them to do the Consguard or a modified Consguard program, which I presented back to the group and they were happy with it. Instead of it being 5 double leg exercises, it's 2 single leg and 1 double leg exercise. So back front squat or a split squat, leg press and knee extension if they're not too ultra and they can do it. They'll get to a point and because of the lever arms where doing the extension is quite painful. When it gets it to a certain weight, they don't like doing it because they get patellofemoral issues or their patellar tendon starts to hurt. But I'll give them 3 exercises. It starts with volume and whittles down to something with higher intensity. So um, that's kind of how I would treat patellar tendinopathy, how we treat patellar tendinopathy. We don't use injections because they ruin the tendon. We don't use corticosteroid injection because that really ruins the tendon, and I see that intraoperatively. Uh, Shockwave, nah, it doesn't really seem to do much. Oral anti-inflammatories, sure, get it to settle down so that they can do their loading, but other than that, in terms of patella tendon, there really isn't that much that we can do to treat the tendon because biologics, and you live in the United States, I live in England, we don't do stem cells here, thank goodness. But we don't find that, PRP and all the blood injections and biologics, they don't really, as far as I'm concerned, they don't really have a huge role in patella tendinopathy. They might have a role in the Achilles, mainly because you can get the loading rates high enough without them being too painful, because the loading rates are double that in the Achilles compared to the patella tendon. But yeah, biologics. I think on at one point in my life I probably sat on the fence, but now I'm firmly on one side, which is don't use biologics. If you don't respond to a good loading program, biologics are probably not going to work for you. And in fact, our problem is that when we operate on them, I have an operation to do in on the 31st of December, so what do you call it, New Year's Eve, to do an operation. Um, when we see these patella tendons that have been injected intraoperatively, they look terrible. Lots of fat infiltration between the tendon fibrils, adhered fat pad, thickened fat pad, really, really, very stiff and difficult to debride tendon fibrils, particularly when it's all matted and fibrillar and disorganized. So, yeah, that's a long answer to a very short question.
No, I love it. I love it. So is it kind of like the same with Achilles tendon when it comes like loading, when it comes to managing it, and when it comes to like injecting like corticosteroid or shockwave?
So I'll address one of those parts first. Corticosteroid has no place in management of weight-bearing tendons. No place. Last week, we operated on a football player, and she's a female football player who had a corticosteroid injection, plays for a big team in England, and she partially basically tore the anterior part of a tendon away. Now, she has unusual anatomy, but corticosteroid has no place in the management of tendinopathy, so we'll park that one. Um, I think in the Achilles, the differential diagnosis is very important because you can get lots of sub-diagnoses within Achilles tendinopathy. So you can get a paratendinopathy, which is the skin of the tendon. You can get, a linear defect within the tendon. So because of the nature of the loads and the tendon spins, the fibrils, some of the fibrils can let go. So you can have a little tear. You can have what is not commonly understood in America, but very widely understood in Europe and the rest of the world, is plantaris-related mid-portion Achilles tendinopathy. And that's essentially a vestigial tendon. You have one in your forearm called palmaris longus that sits and rubs along the Achilles tendon. You can have a Haglund's, so down at the insertion where you've got a bit of a bony bump, and we resect those minimally invasively as well under ultrasound guidance and fluoroscopy. There's lots of different diagnoses. We use for plantaris related, for example, we will use Ostanol, which is hyaluronic acid, which is what people put in their face sometimes, but it's a viscose supplement that's used in knees and ankles and hips. We use that between the tendon. We might sometimes put it to push the fat pad down if there's some vascularity coming up from the fat pad because the tendon itself is not healthy, or underneath the paratenon. So, but in terms of other injections, we might occasionally do a PRP. We might do maybe one a month, if that. So not a lot of PRP, because what happens is you create this inflammatory storm. You have to put them in a boot, so you deload them because they're sore, and then you reload them. And so you've gone back a week, 2 weeks to then go forward because they're already deconditioned because they've been in pain. And so potentially doing PRP, look, sometimes we've had some luck with it, but I wouldn't hang my hat on it. I had a PRP in my elbow because it was the last resort before I had surgery. And it made me, and it had nothing to do with, who did it for me. It was John. I love John. It just was never going to work. I had a big tear in the tendon when the surgeon went in and operated, and I had my extensor tendon repaired. I just sometimes I think PRP, it's gone the way of uh, something that's used too frequently with a poor understanding of the diagnosis. The diagnosis in Achilles is very important.
Hmm. All right. So Uh, I want to talk about loading for
Hmm.
Achilles tendon, and I know a lot of football teams they do isometric or loaded in the plantar flexion position, and some of the coaches say like uh you need to load the Achilles tendon in the dorsiflexion position. Your thought, like any thoughts on this?
I mean, ideally, you would load through range. So if I had a normal, healthy athlete of any nature that doesn't have an Achilles pathology whatsoever, I would load through range. End range dorsiflexion, which we published a paper on at Imperial, and Marvin Chan was the author. I think he's actually from Korea, maybe
I think
Taiwan.
that name sounds like China.
No, he's not, definitely not Chinese. Um, anyway, he published a paper. I was one of the authors on there where we looked at the effects of end range dorsiflexion on the load through the tendon, and end range dorsiflexion is really important. I think there are ways to. I mean, the tendon doesn't know what position it's in. It makes no difference for the tendon. All it knows is strain. That's it. It doesn't even know the contraction type. It just knows it's being pulled on. So doesn't make a difference isometric, concentric, eccentric. Eccentric just means that there's an overload, so it's very, very heavy. Isometric is probably less heavy, and concentric is less heavy again. But the concentric component is important. So is the eccentric component. Um, would I load in just plantar flexion and just do isometrics? Absolutely not. My loading programs have variable foot position, so different position of the foot. It loads through range if they're normal, healthy. There's an isotonic, so concentric, eccentric, and then there's an isometric. So they have different load magnitudes on them because obviously you can hold a lot more than you can push concentrically. And eccentrically, you're probably even higher because it's a yielding. If you do eccentrics properly, you cannot hold that weight. It should be a yielding contraction. Um, but do I bias just one contraction type? No. If I'm trying to work on the tendon, as I said, only knows strain. It doesn't know the contraction. It doesn't even know if it's upright, horizontal. It knows no difference. So does the contraction type matter to the tendon? No. Does it matter from a performance point of view? It's hard to say. If you're loading, that's why I always say if you gave me a normal healthy athlete that needed to do an off-season loading program, they would do, if it was the Achilles, I would do Sydney calf raise through full range. I would do straight leg calf raise through full range. And I'd probably do a very, very super maximal isometric. And they'd hold for 3 to 5 seconds. Variable foot position, done. Three exercises, three different contraction types, but one isotonic, one isometric, done. Oh, sorry, two isotonic, one isometric, done. Three different exercises. Can you get an athlete that wants to be on court to do all of those three kinds of things? Not really, but we're talking off season. If you can keep an athlete off the gym floor for 4, 6, 12 weeks, which is not realistic, but if you can keep them off the gym floor for 6 to 8 weeks and give them a good loading program, makes a big difference.
Hmm. All right. What about those guys that already have some sort of like tendon injury or like tendinopathy they've been dealing with? Or tendon pain.
Yeah, I guess it depends on where it is. So at the insertion, it's likely that they could have a Haglund's. And so that would be very difficult to manage in end range dorsiflexion. You wouldn't load them to end range dorsiflexion. If they have medial sided Achilles pain, it's likely from their plantaris tendon, likely, not exclusively, but likely. A lot of people, 95% of the population have a plantaris longus. So I wouldn't load them to end range dorsiflexion with a straight knee. So part of my role in advising some of the performance and medical teams, because I don't advise players themselves, is that player has a Haglund's or that has insertional changes. What I suggest is we just modify their loading strategy, or they have a large plantaris tendon in close opposition. Let's just be careful loading them with a straight knee off the edge of the step, heavy.
Hmm.
So we do vary. their loading strategy depending on their either pathology if they're symptomatic or their anatomy. So
Hmm.
I've seen in the past, some very interesting patella tendons, but some that have very, very sharp and beaked inferior patellar pole. It basically looks like a spike sticking into the tendon. And so would you load that into end range, knee flexion? No, you wouldn't, because you're basically just that inferior patellar pole, that beaked inferior patella is going to stick into the tendon. And that does cause tendon damage, compression. So
Nice. All right. So, um, you kind of talk about like off season. How would you load it? But what about during the season or like yeah, during the season, as the seasons goes on, like they're exposed to more and more plyo, high speed running, change of direction. How would you manage that?
yeah, I mean, it's very difficult. That's sort of the age-old question, whether it be in the NBA or Premier League football, Championship football here, soccer here in the UK. It's very difficult, and there isn't an answer that is the right answer. It is based on the pathology. So, how bad is their tendinopathy? Number one. Number two is the position of that player, how many minutes they play, what what surface they're playing on, football versus basketball. Um, and then their training load. So is their training load really, really high versus their game minutes? Yes, they should do loading. Can they do a modified cons guard 3 times a week in season, 3 exercises, super, super heavy? No, they can't. It's not practical. Um, can you do that during the All-Star break? Absolutely. Brilliant. Perfect time to do it. Or when all the teams were doing the in-season tournament in Vegas. Perfect time to do it. Implement a loading strategy for those athletes that are symptomatic. But can you do that kind of loading in season? No. So, it's probably a little bit of microdosing, just dropping in a bit of loading, whether it be after a game or whether it be, after a session that precedes a day off. Each athlete, depending on how they're profiled, how strong they are, what their deficits are, you maybe want to address them. But the majority of the meaningful work that you're ever going to do with an NBA player, because that's how we know each other, we'll talk about that. The majority of it is going to be off season. That's how you're going to move the needle. That's how you're going to address some of these problems is the off season, because the NBA, if your regular season finishes mid-April, and they go back into September. That's a huge chunk of time to change an athlete. And I mean, the wonders of things you can do with an athlete with that much time. They can lose body mass, which is important to manage tendinopathy. You can get them super strong, you can get them super fast. What I encourage people not to do in season is do more plyos, do more jumping. They jump enough. There's no need. That's not the medicine for the tendon. The medicine for the tendon is strain and loading. And so I see sometimes, the programs being built, a little bit of strength and then lots of players. Yeah, I mean, these guys don't need to jump any more than they already do. Um, so I sort of park the players, unless they're a rehabbing athlete, then that's one thing. But if they're a playing athlete with moderate to high minutes, then there's no reason to do any players.
Mm. So, I want to backtrack a little bit to the patella tendon, and in that area, there's also like quad tendon and patella tendon. So,
Mm.
you talk about like knee extension. Like if it's like like if there's like quad tendon, would you load it differently than patella tendon?
Yeah, I mean, I think quad tendon you need to load into a slightly deeper amount of range, deeper knee flexion. But other than that, no, I mean, I use the same principle, modified cons guard program, but slightly deeper knee flexion if they can tolerate it. And you might put them into sort of like, a lunge type position with dumbbells, front front foot elevated and lunge into it. That's a nice way to do it. It's difficult, it's challenging, and they do get quite a good quad burn or a quad Nordic. That's a nice way to, which is like a hamstring Nordic, but the other way around, where they sit on the backs of their heels and sort of lean back. They might have a plate. That's a nice way to load the quad. But yeah, it's slightly deeper knee flexion range.
Hmm. All right. So, uh, we kind of talk about like loading the tendon, talk about like how we manage it. So want to go back to the first conversation we had in summer league
Mm,
about the
your memory is better than I. Yeah,
no, I just want I just still want like because actually you are the first one that tell me that uh injury mechanism probably really that matters that much. Because before that, like I was like really like learn like diving into like all the injury mechanism terms like Achilles tendon whatsoever, hamstring whatsoever. But after our conversation at like summer league, kind of talked like different uh PT, AT, and strength coach. What's interesting is a lot of strength coaches are trying to like learn more about the biomech biomechanics of injury or the mechanism.
Mhm.
But if you ask like PT or A probably PT or AT, they kind of don't agree with that. They're like the mechanism is the mechanism. You can't do anything about that.
I mean, the NBA is, has set up a biomechanics element to testing now, which I shall hold my comments on. Um, maybe that will reveal something interesting. Um, look, I think there's some things that you can change. But if you said to me, what is the best way, the most effective, the most researched way to prevent tendinopathy or rupture, there are the things that I talked about before. I would probably call, biomechanics. I run a biomechanics lab in the NBA for years. Using Burtec plates, which is what they're using now, using Vicon or using a Noraxon system. So, I think there's things that you can change, movement mechanics, trunk control, knee and hip position. But I think if you're looking to use biomechanics to limit the rate of or the prevalence of Achilles ruptures, I think you would might be, as the expression is, barking up the wrong tree, because I'm not sure that that is where, I know that there was I forget his name again. He presented at the NBSCA in Vegas. Anyway, he talked about, shin angle, that when you get over a certain amount of dorsiflexion, why are you laughing, Eric?
No, nothing.
You know what I'm going to say? Yeah. So he talked about that when your shin angle goes over a certain amount of dorsiflexion, that you're likely to injure your Achilles tendon. But my comment back to that is, again, you can't change these athletes stepping back the way that they do. The dorsiflexion angle is just how they function. You're not going to change that, because if you put every person that ruptured their Achilles, Ty, Jason, you know, um, Dame, if you said, guys, hey, you can't go past a certain amount of dorsiflexion, you're never going to change that. So it may be of interest, but you're not going to change it. So if I said to somebody, yeah, your dorsiflexion angle is too high, the only thing that you could possibly do to fix that is maybe give them a slight heel raise, but they're already in one anyway in their basketball boots, and just make them stronger so that they can control that range of movement. That's it. So, coming back to your question about ATPT versus strength coach, I think it's all interesting, but I think it comes down to what does the research say, number one? Number two, the only thing in terms of tendinopathy that is shown in terms of biomechanics is those that are overpronators potentially might get more tendinopathy, or there is an associated risk of developing tendinopathy if you're very, very pronated. But that being said, there are a lot of athletes in the NBA that are very pronated and have no Achilles tendinopathy. So, um, problem is you're looking at a very unique cohort. The NBA is the 0.1% of elite athletes in the world. They are a terrible cohort to draw conclusions from because they're unusual movers. They, Kevin Durant, he's 7 foot tall and he moves like he's 6 feet. He's an incredible athlete. LeBron or Thai or all these, they all move very, very differently. And so you can't draw these conclusions. You can't say that, you move differently and you've got to change how you move because you go over a certain dorsiflexion angle and your risk of Achilles tendon rupture is higher because you go into more dorsiflexion. That's not gonna wash. So how do you affect change? What are the things that are modifiable? Back to my original point. Do the things that are modifiable.
Nice, nice. I love it. I love it. So, all right, I'm gonna ask you a stupid question again, but does that also mean like other injury mechanisms kind of the same?
No, I think groin injuries. I think there's some interesting biomech data around that, and that was done by SSC, Dr. Chris Richter and Enda King, where they talked about trunk position. ACL, we do know that if you've had an ACL injury, the position of your center of mass and your trunk position is altered as a result of suffering an ACL. Can we predict these injuries? Absolutely not yet. There are too many factors that um, that cause an ACL rupture. And then, frankly, there aren't enough of them in the NBA to really want to sink hundreds of thousands of pounds or dollars into looking at injury mechanisms around ACL rupture. Maybe in the NFL, but again, a lot of them are contact injuries in the NFL that you can't do anything about. Um, but yeah, I don't know that sort of answers your question. I kind of forgot
Yeah,
what I was going to say.
yeah,
What
yeah.
was your
That's
question
good.
again, Eric? I'm
Yeah.
really tired, so I've been getting up very,
No,
very
you're good.
early
You're good. Like
to rehab somebody.
this is really good. This is awesome. I love it. So that's basically all the question I have for you today. Appreciate it.
Okay, pleasure.